Okay, thank you for joining us today. Today we have Dr. Hassan Malik, a frequent speaker in our webinar series, joining us from Liverpool in the UK. Thank you, Dr. Hassan. Always a pleasure to have you with us. And Dr. Hassan will be talking about retroperitoneal sarcoma surgery. Thank you for joining us, and the floor is yours.
Thanks again, and thank you for your kind invitation. This is probably a similar talk to what you may have heard me give previously, with some few modifications, but we can go through it and then I'm happy to take questions. As someone who, part of my job is hepatability, another part is sarcoma surgery. And as part of sarcoma surgery, we also see patients with desmoid tumors, fibromatosis. And I thought I might just cover that briefly before I go into the main talk, which is about sarcoma, because I think it's relevant and these are cases you will see. So fibromatosis is rare. These are rare tumors. There's a number of recognized risk factors like genetic conditions like polyposis coli, Gardner syndrome, etc. They're benign tumors, benign lesions. They will not become malignant, but they behave in an aggressive fashion. They're often asymptomatic. That's important to remember. They can be picked up incidentally, and crucially, they can regress spontaneously. So because of their unpredictable behavior, we normally would advise active monitoring up to 2 years based on clinical risk. Active management, i.e. some form of medical intervention, is reserved for patients who have symptoms, or if it's adjacent to critical anatomical sites or in patients with familiar cases. The management is often divided into medical management, so this can be as simple as non-steroidals or tamoxifen, or kinase inhibitors like sorafenib, or in more aggressive cases, cytotoxic chemotherapy. Surgery is generally reserved for abdominal wall lesions, which you may require an abdominal wall reconstruction, which you can do either yourself with a plastic surgeon, or when you've got critical intra-abdominal structures involved, like around the small bowel is a key area, for example, around the SMA, SMV. You can also consider radiotherapy as an adjunct to treatment if your histological margin is positive. But crucially, this management should be through the Sarcoma Tumor Board. This paper was published a few years back by some key players within sarcoma surgery, published in JAMA, and it's a really nice synopsis of management of this disease. And as you can see, surgery is really reserved for those areas that I mentioned. So that's a kind of very brief thing around desmoid tumors, because you will potentially see patients in your practice who have this, and it gives you an understanding of how to move forward with those patients. So the main talk is going to be about sarcomas. Now, sarcomas are rare cancers. They're less than 1% of all cancers. There's around 120 different histological subtypes. There's a number of risk factors, and this includes previous radiation. So we do see a lot of sarcomas in the chest wall related to angiosarcomas after radiotherapy for breast cancer, for example. It can also be associated with genetic conditions, for example, neurofibromatosis. And with that, there's a very specific type of sarcoma that you can get called a malignant peripheral nerve sheath tumor, which is very aggressive. Or it can be related to cytotoxic drugs. So although sarcomas are rare, retroperitoneal sarcomas, which is the focus of my clinical practice, is a rarer component of a rare cancer. And about 1 in 20 sarcomas will be retroperitoneal tumors. There's a number of different histological subtypes, the commonest being liposarcoma. They often present late with non-specific symptoms and are diagnosed on cross-sectional imaging, which may have been done for something else. Biopsy is only advised if imaging is inconclusive of sarcoma diagnosis. And again, I would not advise biopsying these until there's been discussed at the Sarcoma Tumor Board. So the vast majority of retroperitoneal sarcomas fall into 5 main subtypes, which are described here. So the favorable prognostic tumors are the well-differentiated liposarcoma. Often the long-term prognosis is in excess of 50%. They tend to recur locally, but rarely metastasize. Or the solitary fibrous tumor, which is basically a solid mass. They tend to recur locally if incompletely excised, but metastatic disease is exceptionally rare for those. The poorer prognostic tumors are either the dedifferentiated liposarcoma, which can be divided into either intermediate or high grade. The higher the grade, the higher the chance of metastatic disease, and that metastases is to the lungs invariably. Or sarcomas. Again, the risk of metastases is high rather than local recurrence. And again, because the balance of local recurrence with metastatic disease, you can tailor the surgery accordingly, and I'll discuss that later on. And this thing called malignant peripheral nerve sheath tumor. These are very aggressive tumors, often associated with neurofibromatosis. I've done a few operations for these over time, but they generally tend to recur very rapidly and often are fatal. Now, the majority of sarcomas are chemo-resistant. Surgery really is the only thing that offers the best chance of cure. Local recurrence remains a problem. So in terms of who should be operating on sarcomas, well, there are some guidelines that we have. So in the UK, the traditional definition of a sarcoma unit is to treat 100 sarcomas per year, per annum. And this is all types of soft tissue sarcomas, including retroperitoneal, limb, head, neck, gynae, thoracic, whatever. This is not bone sarcomas. Bone sarcomas are a different entity, which are done by different specialists. There is a new service specification which is suggesting we should be doing 24 resections, seeing 24 patients per year. This is slightly controversial, and I'll go into a bit more detail about that later on. At a European level, ECHO sets out a minimum of 100 cases. So this is not the numbers of patients reviewed through the tumor board, but actually the number of operations. So a minimum of 30 resections of all subtypes of retroperitoneal sarcoma per surgeon. So that's quite a large number, but that assumes that the surgeon is operating on intra-abdominal and extra-abdominal sarcoma, so a mixed kind of group of patients. In the US, the various sarcoma alliances set a minimum unit volume of about 50 resections. So there's variation between the UK, the rest of Europe, and the US, for example. But when you look at a lot of countries, generally you have one or two centres that do the highest volume, and this big tail of centres beyond that. And this all describes this idea of variation in healthcare. And it's important to understand that when you look at variation in healthcare, it's important to reduce the bad type of variation, which reflects the limits of our professional knowledge and our failures in application of that, while preserving the good type of variation, which makes care centered to that patient's needs. Now, if you look at the world literature, Sloan Kettering in New York is probably the center that's done the most resections globally. But there's a number of multi-center series published. Now, this group is quite important. This is the Transatlantic Retroperitoneal Sarcoma Working Party. They started off with 6 European and 2 US centers. They published probably almost a decade ago a series of 1,000 just purely liposarcomas resected over 10 years, an average of 12 and a bit resections per year per center. The 90-day mortality was 4%, with excellent 5 and 10-year survivals, as you can see there. The MD Anderson looked at US data, looked at volume and outcomes, and high volume centers were described as doing more than 10 resections per year. And high volume centers, using their definition, were associated with lower perioperative morbidity and mortality, reduced readmission rates, and a marginal difference, but certainly a statistically significant difference in 5-year overall survival. Now, when you come back and look at this transatlantic working group, and you look at their outcomes compared to that of any generic hospital in the US with the SEER data, there certainly does seem to be a significant difference there. And this transatlantic working group will recommend a minimum of 30 resections per center per year. So that's what they're setting as a standard. Now, obviously, since then, things have moved forward in the UK specifically, and there's a couple of things I want to briefly discuss. So this was an important paper that was published in the British Journal of Surgery 2023. We were involved in this. So this was led by the group in Birmingham, which sent 21 blinded cases to all the sarcoma tumour boards in the UK and asked them to discuss decision management and strategies. And what was interesting is there's a lot of variation that you can see in terms of definition of resectability between the centres. And interestingly, also a lot of variability in what type of operation that they would undertake, whether it would involve vascular resection or not. So that's quite interesting that even though you have a constituted tumour board, which is supposed to have a level of expertise to be able to manage these patients within that group of tumour boards, and these are all experts, they're all doing a reasonable volume of sarcomas around every year. There's a lot of variability in their decision making, and that, if would be slightly concerning if you're a patient. The other thing that has followed this publication was looking at HES data. So this is hospital statistics data. This is NHS England data over a 5-year period. So this was from 2013 to 18. Identified almost 1,900 patients with retroperitoneal sarcoma. 60% of those had an operation. And they divided centres into high volume and low volume specialist centres. So the definition was taking the top 3 centres in terms of volume and looking at their average resection rates, which was 24 cases per year, and looking at their outcomes versus everyone else. And so this is what they found. Well, they found that at 5 years, the survival for those high volume centres was marginally different, but statistically so, than the lower volume, but still specialist centres. So that's the light blue curve and the purple curve. Whereas the dark blue curve is the patients who've had an operation for retroperitoneal sarcoma in a non-specialist centre. Really, that should not be happening, but it may be they thought it was a renal cancer or whatever, or a GIST or whatever it may be, and they did a resection and it was a sarcoma, and then it was referred to the tumour board. But when you actually look at the volume per centre, what's interesting here is the one centre, and this is the Royal Marsden, does the most, and this would fulfil the criteria for 24 resections per year as endorsed by this paper. But no other centre, even the other 2 centres, which are deemed to be high volume, would not reach that threshold. Liverpool is here, so we're here, so we're just shy of that. But you've got one centre here that does the most, and this other here, which you can see on my arrow, is a group of 3 hospitals that have pulled their data together. So at the end of the day, we can talk about super centralization and all that, but the reality is there's consequences of that, especially in terms of being able to deliver good care and emergency care closer to the patient's home. Now, when you've done the operation, let's say, there's a number of predictors for outcome, and this was again work from the transatlantic group, looking at nomogram for outcome. And the key thing here is the only thing you as a surgeon can predict is the margin, right? So if you can remove the tumour completely, then it at least gives a chance of long-term survival. Now, in terms of improving disease control, what else can we do apart from surgery? So there was a meta-analysis looking at the role of radiotherapy, and this is again using kind of SEER type US data, and so there's what they looked at is radiotherapy showing that it's safe, but its effect on survival and local control at that stage was unclear. This was again a further study looking at retrospective US cancer registry data in over 9,000 patients, again, suggesting both neoadjuvant and adjuvant radiotherapy seem to have a benefit in terms of hazard ratio and p-values. But at the end of the day, the only way to test this is a randomized trial. So this was done. It was closed. It completed recruitment and showed no benefit from neoadjuvant radiotherapy. So we then have moved on to the STRAS-2 study, which is looking at neoadjuvant chemotherapy in the biopsy-proven high-risk sarcomas where there's a high risk of metastatic disease. So not the standard liposarcoma. So this trial is currently open in Europe, including our center. So now coming to the actual operation. So the key thing for this is you can often get massive tumors like this. So this was a case I did probably around 2009. This was a 20-kilogram tumor. And the key issue here is access, abdominal access. So what I tend to do is start with a long midline incision. I'll extend it either to the right or the left based on which side of the abdomen the tumor is mainly on. You often will have to resect adjacent organs. So it might be kidneys, colon, pancreas. And so this is an example of a tumor that's located in the left upper quadrant in whom we undertook section of the diaphragm, stomach, spleen, distal pancreas. If you've got a tumor centrally, that is more challenging. And this is an example of a centrally placed mass. You can see the heterotrophic calcification here. So the actual extent of the tumor is far larger than the solid component because there's a lipomatous component which is also malignant. And here the patient required a Whipple, a right hemicolectomy, a right nephrectomy, and IVC resection. And this is the intraoperative photos here. And you can see the whole SMA, SMV has been sclerotinized from the iliac colics all the way to the liver. This is another example of a tumor that's arising basically between the spine and the vena cava, so pushing the liver anteriorly. And in this particular case, we did this on bypass. So these are various steps. This is on the cardiac bypass machine. This is now having divided the vena cava and lifted the liver off the retroperitoneum. You can see the liver. I don't know if you can see my arrow, the liver and the IVC, and the tumor is here on the spine. And then we resected this, and then that's the tumor, and then we re-implanted the IVC there. So the aim of surgery is to achieve a complete macroscopic clearance, which is described as R0-R1, because obviously the surface area is very large in these tumors, and so that's the way the pathologists will report it. If adjacent organs are involved, these must be removed. But the Milan group do advocate this idea of a compartment resection. So whether it be the right or the left side, you would remove the colon, for example, the tail of the pancreas, spleen, even if it's not involved, to achieve better control. So if you have a picture like this of a sarcoma, the resection plane is there. So you start in the midline, you get into the preperitoneal plane, and then you strip the peritoneum and the preperitoneal fat off the midline all the way around onto the psoas and then up towards the spine, and all that is taken en bloc. So the whole paracolic gutter is excised en bloc with the tumor. But this approach really is only reserved for liposarcomas where the issue is of a local recurrence rather than metastatic disease. For solitary fibrous tumors, leiomyosarcomas, etc., we don't do this approach. It's only just for the liposarcomas. That includes the D-differential liposarcomas. So going back to our practice, so we had centralization of retroperitoneal sarcoma surgery in the northwest around Liverpool back in 2011. So we were managing patients just within Merseyside, and then the Lancashire Cumbria network, which is this area here along the coast of England, the west coast of England, and has come into our networks. We have a population of just under 4 million. So since 2005 actually, my predecessor, Professor Poston, who's now retired, led this service. I started sarcoma surgery back in 2009, shortly after I was appointed as a consultant. We've done about 265 resections in 200 odd patients. But we've actually recently submitted a paper to the EJSO, which has gone through peer review, and we've been asked to provide some revisions, corrections, which we've submitted. So we're hoping it will be published, but it's not been accepted as yet. And I want to share some of this more recent data. So we've looked at 10 years worth of data between 2012 and 22. So 85% of our patients have undergone curative intent surgery compared to the national average, as I mentioned earlier, of 60%. So that's 105 patients who underwent a total of 156 resections, and the 30 and 90-day mortality is similar to the published literature that I've described before. So when you divide the patients into low risk and high risk, about a third of our patients were low risk and 2/3 of our patients were high risk. So at 5 years, the patients are low risk, have a 5-year survival of about 75%, and the patients who are high risk have a 5-year survival of around 50-odd%, and long-term survival is also achieved. Just over half our patients had multivisceral resections, and this is an example of a patient we were sent from elsewhere as a second opinion of a tumor arising from the vena cava. You can see the forceps in the vena cava here, and the IVC was replaced with a Dacron graft. So when we look at multivisceral resections here, we've done quite a few vascular resections, IVC resections, resections of the aorta, resections of the iliac arteries, resections of the iliac veins. So we've done quite a few of those. We've also done a number of HPB resections, including liver, left pancreas, and Whipple's. We commonly do colonic resections, and nephrectomies quite commonly with adrenal glands, etc. So these are all operations that we do ourselves. If we are doing an aortic or arterial resection reconstruction, I will get a vascular surgeon who I work closely with to support us. So I think it is important, and I want to get this message out, that once you've done the operation, there's no real evidence for adjuvant therapy, but it is important to monitor these patients. And there's a lot of guidelines that are variable. Often the guidelines will suggest a chest X-ray and nothing else. We have been doing cross-sectional imaging on all our patients for at least the last 15 years. And I want to share this key message from our paper. So when we look at the patients who had a resection over this time period, just over half have had recurrence. The majority of that is intra-abdominal relapse. 10% of our patients have oligometastatic relapse, and the rest will have multi-site recurrence. 80% of the patients have intra-abdominal recurrence, and all those who have oligometastatic recurrence had radical treatment. And this is an example here of a patient with a recurrent Ewing sarcoma who had that resected with a graft replacing the vena cava, and they had about 2/3 of the liver resected. So what's the benefit? Well, actually, if you do re-resections, our 6-year survival is about 75%. And why 6-year survival, I'll explain that in a second. But also, if you've got oligometastatic disease, you still get a 5-year survival of around 50%, which is phenomenal, compared to chemotherapy, where the 5-year survival is probably around 15 to 20%. So statistically significant differences in outcome for either resection or local recurrence in the abdomen or oligometastatic disease or above and beyond palliative chemotherapy. So going back to, again, the transatlantic group, they looked at recurrence. Of the 9 centers, they'd done a total of just over 684 resections, averaging 31 resections per center over that time period. Their 6-year overall survival was about 54%, so slightly less than what we've quoted. And they developed a nomogram, again, describing the factors that predict long-term good prognosis with re-resection for sarcoma. So the message is that you can re-resect recurrent sarcoma in the abdomen, and it's important to, and you can treat oligometastatic disease. That's often liver or lung metastases, for example. But then, in order to identify those patients, it's important to image these patients. So anyway, wrapping it all up, okay, so I think we can all agree that there is a push towards centralization for these rare and complex cancers. Multimodal treatments may, improve outcomes, but the mainstay of treatment is surgery, okay? I think it is important that we do post-resection radiological surveillance. And there is an neoadjuvant trial that's currently open looking at patients with high-risk retroperitoneal sarcoma. I think that's all I've got to say. I'm going to stop sharing, and then I'm happy to take all your questions.
Okay, thank you for the interesting talk. If you have any questions, please raise your hand. I have a question myself here. When you mentioned you did 220 cases in the last 20 years, right?
So we've done about 260 something cases since 2005.
So that's like 20 cases a year. So that's less than the amount you were talking about earlier.
Yeah.
Right?
So what I would say is a couple of things to that. So when I started in 2008. The data goes back to 2005. Between 2005 and 2009-10, when I got involved with sarcomas, we were doing 2, 3 a year or whatever. In those days, very few cases were getting done. What we've seen is a big increase in the numbers. So probably somewhere between 15 and 20 primary resections per year, and a few re-resections. So probably between 20 and 25 resections in total, including primary and redo. That's what we're currently doing. But it's taken a long time to get there. I think the problem with this number that's been referenced, it's based on 3 centers pulling the data and saying this is how many we're doing, and that's the bar, okay? But if you look at those 3 centers, one's doing a lot, then there's another bar which is 2, 3 hospitals pulling the data, and then there's one other group which is part of those top 3, and then everyone else. So I completely agree, we shouldn't be doing 1 or 2 a year. Whether we should be doing 24 a year is open to debate, and there's an active debate in the UK about where we should be at. So the only way things would change is for NHS England to say, okay, guys, this is what we're going to do, and then commission services based on that. So I think until that process happens, I think centres will continue to do the volume that they're doing. Some centres may decide, well, we have workforce issues, we don't have enough trained people, we'll just stop, in which case that work then goes somewhere else.
Okay. 24 is not bad. 24 is a case every 2 weeks.
Yeah, I know. All we can do is publish our data, which we've done, and we're continuing to do, and then that allows us to benchmark what we do with everyone else.
Okay. Dr. Mahmoud Khalil.
Okay, thank you, Dr. Hisham. Thank you, Professor Hassan Malik, for your comprehensive presentation as usual. I have 3 questions if we have a time for this. The first one, if I had a well-capsulated huge retroperitoneal sarcoma occupying مثلا as anatomical site right hypochondrial region extending to right iliac fossa, can I go for surgery, just surgical excision with intact capsule, or you prefer to go for compartmental resection?
Yeah.
Even it was as easy surgery, يعني I don't need to do this major surgery.
Yeah, so it depends on what it is, so if it's a liposarcoma and it sounds from your description that's what it is, it will almost certainly be encasing the kidney and so you will have to do an nephrectomy. The question is, do you have to do a right hemicolectomy or not? And so there is one argument that, okay, if you can mobilize the mesentery of the colon off, etc., do you genuinely need to do a right hemicolectomy or a left hemicolectomy if it's on the left side because of the risk of anastomotic leak or whatever? And you can make that argument both ways, but certainly if you look at the experts, in this, and for liposarcoma, they would always say, look, if you try and preserve the colonic mesentery, there will be microscopic disease, you will get recurrence there. And so they would always advise in liposarcoma to resect the colon, the kidney, everything, okay, in this kind of en bloc manner. Whereas I think if that en bloc approach includes a Whipple, for example, then that massively increases the risk. So there we have to have an element of pragmatism and look at patient fitness and things like that. So it is an area of kind of discussion. Let me say it that way. If you've got a different type of sarcoma, like a solitary fibrous tumor, which is massive, or leiomyosarcoma or whatever, then you don't need to do that. Then you remove the solid mass. You don't have to do this compartment thing because certainly for leiomyosarcomas, for example, the risk of metastatic disease is much higher than local recurrence. So you tailor your surgery to remove the tumor because the risk of relapse is elsewhere, not in the retroperitoneum. I hope that makes sense.
Okay, I got it. But regarding the advice, you said that we don't need to take a biopsy only if we have a suspicion for radiological diagnosis. So I don't know the histopathological type of the sarcoma I will manage. So I can decide to do which approach I can go forward.
So your radiologist can often tell you, so what you will see on imaging is a large lipomatous mass, okay, which may have a solid component within it. So that would be classical of a dedifferentiated liposarcoma, the solid bit, or you may see a huge lipomatous mass, which is classical of a liposarcoma, a well-differentiated liposarcoma. So if you see that, radiologically, you're calling it a liposarcoma, in which case you would do this compartment approach. If you've got a solid mass, you're not sure what it is, then obviously there's a number of differential diagnoses, and this includes lymphoma, it includes germ cell tumors, it includes benign peripheral nerve sheath tumors like schwannomas. And so for those things where you've got a solid lump, you're not sure what it is, yes, I would do a biopsy. You may add tumor markers like beta-HCG, AFP, if you're worried about germ cell tumors. For example, you may do all the things for functional tumors, like pheochromocytomas and things in case you've got a mass around the adrenal, for example, because these patients will present to an adrenal tumor board or an endocrine tumor board or general surgery tumor board. So it's important to be aware that there are differential diagnoses in this. But a liposarcoma in imaging is pretty classical. So if your radiologist sees a big lipomatous mass from the diaphragm to the pelvis, it's a liposarcoma.
Okay, the second question regarding some cases in the presentation who had vascular resection as IVC and repair. These cases had systemic neoadjuvant or radiotherapy or go for surgery first.
Yes, in terms of the vascular resections you're talking about.
Yes.
Yeah. So for us, if it's operable, we will resect. As I say, there's no real strong evidence to support neoadjuvant radiotherapy. The trial was negative. But if intraoperatively there's an area that I'm not 100% comfortable with, I'll mark it with surgical clips for adjuvant radiotherapy. So that's an option. In terms of neoadjuvant chemotherapy, again, that isn't something that is currently. So if the patient's fit for an operation, you think as a surgeon you can operate, we would tend to operate. But there is the trial that's open, which is a difficult trial to recruit into, I have to say, but it's only reserved for a certain biologically high risk types of sarcoma. So for that trial, you do have to do the biopsy to confirm the diagnosis and the subtype of sarcoma to then offer chemotherapy in the neoadjuvant strategy. Now that trial may be positive, it may not be, I don't know. But certainly what you're trying to describe is downsizing treatment to try and facilitate an operation. I have to say, in my experience, the only thing that's so obviously the patient has to be fit enough for an operation. These are operations which have risks. But in terms of what's technically resectable, I think the only thing that makes these irresectable is encasement of the SMA, SMV, in which you cannot save the small bowel. I think the IVC we can resect. We've done resections around that. The aorta we can resect, put in a graft. Obviously, we have an experienced team. We have vascular surgeons involved. We can bring in pancreatic surgeons if we need, whatever. We really require urologists unless, for example, we're going to do reimplantation of the ureter, for example, is one example there. So what I would say is that if it's operable based on your assessment as a surgeon and the patient's fit, you operate.
Okay, the last question. I'd like to ask about your experience as an expert in a case of fibrosarcoma with mild peritoneal disease, PCI not more than 10 to 12. What about complete cytoreductive surgery plus HIPEC in these cases?
I know, it's a difficult one, isn't it? So we're not a HIPEC center, so we have no experience of HIPEC. Generally, when you got peritoneal dissemination of sarcoma, these patients don't do well, and we do see this every so often with a large, sometimes some of these tumors are very soft, and if the patient's had any trauma or whatever, they rupture and you go in and you got peritoneal disease. And what I've done, certainly if the patient's young, my heart overrules my head, and I've done the resection because they're symptomatic, and I've done the peritoneal stripping, but we don't have HIPEC. So I think it's a difficult situation. The one type of sarcoma that you may come across as a HIPEC center is this small round cell tumors that you get. So this is a kind of sarcoma variant. They're often young men that we see. And in that group of patients, there certainly is a rationale for aggressive cytoreductive surgery, but these are patients in whom the tumor is very chemosensitive. So the treatment strategy for that group of patients is systemic therapy, then some form of cytoreductive surgery, which may or may not include HIPEC, and then adjuvant chemotherapy plus minus whole abdominal radiation. And that's the strategy that is used for this small blue round cell tumor, which is a subtype of peritoneal-based sarcoma. So that's maybe the area where you could consider CRS. But I think if you've got metastatic sarcoma with what we would describe as abdominal sarcomatosis, like carcinomatosis, but sarcomatosis, I think the prognosis is generally poor. Often we would manage that palliatively. But again, if you have such cases with good outcomes, I think it's important that they're published either as case reports or as a series.
Okay, thank you. Thank you a lot, Professor Hassan. شكرا دكتور هشام.
Thank you.
Thank you. Okay, any other questions? Please, if you have a question, raise your hand. Last chance to ask Dr. Hassan. If you have a question. Dr. Hassan, do you have any questions for us?
No, I think I'd love to, one of these, rather than me talking, have a kind of like an MDT tumor board session, I've mentioned this before, to bring some cases and we can have a two-way discussion, you know. And I hope to see everyone. I'm coming to the Congress in May, so I've been invited
Okay, great.
for the Congress. So inshallah, I'll see you guys.
Which Congress is it?
This is the one in Cairo, the Egyptian Surgical Oncology Congress. Is it there? Is it in
Do
May?
you,
We've had an
do,
invite
do you
through us.
remember the name of the conference?
I'll tell you shortly. But yeah, I think doing a tumor board would be quite useful, which I think would help.
Yeah.
EGSSO. It's a Surgical Oncology Congress.
Yes. Okay. Okay. Great.
Yeah. So I think it's
Egyptian Society of Surgical Oncology.
yeah. So it's in beginning of May, I think, isn't it? I think.
Okay.
So
So we'll see you soon.
inshallah, I'll see you soon. Okay.
Try to keep try to plan a day off, like an extra day, so I can show you around or something.
Yes, definitely want to go and see that. And is the new museum opened?
It will open in July, so not
Ah.
yet. 3rd of July.
Oh well, never mind. Never mind. Okay. No
Okay,
other
it
questions.
was lovely having you, and looking forward to seeing you and to the next webinar, inshallah.
Thank you. Inshallah. Assalamu alaikum.
Okay, thank you all, and good night, everyone. Bye bye.